All right, guys, we are back for our second to last session. And Cesar de Cesar Netto is going to give us the lowdown on this. He's going to be the moderator. You know, we've been through almost the entire 24 hours, barely touching on Hallux Rigidus, which is really surprising, especially in light of Cartiva and things that have come up over the last few years. So this will be an interesting session. You got a great faculty. It's all yours.
Thank you so much, Dr. Parekh. Let me share my screen here. Here we go. Let me know if you can see that. So let's talk about Hallux Rigidus. My name is Cesar. I'm a University of Iowa assistant professor, also running a functional imaging lab there, and I want to keep the doors open at University of Iowa in Iowa City for anyone wanting to come to visit us after this crazy coronavirus time. These are my conflicts. We can check the conflicts of the other speakers online on the AAOS and AOFAS website. I want to thank Dr. Parekh for the invitation, and I would support all of you guys to considering donating for his cause and the cool stuff that he has been doing with the Parekh Family Foundation. I did mine, so here it is, my proof. And without further delay, introducing the speakers and the faculty. So I have I'm very fortunate to have all of them as part of my mentorship and my friendship. I'll start with from Brazil. Alexandre Godoy was one of my mentors there and is a great friend. We spent time together in different fellowships that I did. So thank you so much, Alexander, from University of São Paulo and Albert Einstein, to be here with us. Dr. Johnson was my mentor from my first fellowship in the U.S. Learned tons of things with him in Birmingham, Alabama. Thank you so much, Dr. Johnson, for joining us. Here we go. Then Lauren Roberts was a co-fellow with me in New York City, but I've learned more with her than she learned with me for sure. So I consider her as well one of my mentors. So thank you so much for that and for all the friendship, and thanks for being here. And Dr. Drakos, oh, sorry, I forgot to say that she is at the University of British Columbia in Vancouver. And hopefully we're going to visit her at AOFS. And then finally, Dr. Drakos was one of my mentors at HSS. Dr. Drakos, unfortunately, we don't have a picture together. I found that to be very strange. We have to fix that pretty quick. But this is the picture that we took at the day of my graduation at HSS. Thank you so much, Dr. Drakos, for being here with us. And without further delay, let's go into it. So we're going to do some questions. We're going to do a little bit different from what the other sessions we're doing. So we're going to start briefly discussing about conservative treatment. So Dr. Roberts, tell me about describe your ideal conservative treatment for symptomatic Hallux Rigidus.
Sure. Thanks, Cesar. So in general, I always tell patients easier to change the shoe than it is to change the foot. So let's start with that. And we've got a couple examples here of key components for me. So once it's symptomatic enough to be seeking further care, I think it's time to really make a change in the shoes they're wearing in terms of wider toe box. Generally going through their closet and choosing all the stiffer shoes is an easy place to start. If that doesn't seem to really be cutting it, or they've done that and it's not enough, getting more of a 4-foot rocker shoe, a bit more of an investment into their shoe, or trying a Morton's extension. There's certainly some issues around it being cost prohibitive for a custom orthotic, but often I just get a gate plate and have them modified to include just the extension under the hallux. I've found good success with that, and it's a lot less expensive for patients just getting it over the counter. Obviously, appropriate pain medication and ensuring there's no other components to their foot that's driving their problems. So if there's a role for physiotherapy to maximize their kind of strength and stability through the foot can be helpful. Changing their activity as much as they feel they're willing to. And injections are plus minus for me in my practice. I mean, a diagnostic injection can certainly be helpful if there's any question about the underlying cause, dorsal osteophyte versus intra-articular pain, for example. But overall, I would only say 1 or 2 injections before I'd say we should be thinking about something different.
What would you say is what do you tell your patients? How successful, if you had to give a number to your patients, what let's say a grade 2 or grade 3 Hallux Rigidus that is symptomatic for the last year and haven't tried any conservative treatment, what would be the number you would give them? What is the likelihood that they're going to get better with all these measures?
Yeah, a bit of I don't typically use a specific number in that situation. I think the issue is I don't know the denominator of people in that situation who may or may not have success for this. I am surprised though, and use some examples of patients I've had where they come in ready to talk about surgery, they need an operation, it's that bad. And I say, just give me a chance to give this a go, and they'll try a Morton's extension, and I don't see them back. And so I've only been in practice 3 years, but I think this certainly does extend people's conservative management by at least several years, which has its benefits, and we talk about that too. But I think at their first visit, if they've literally tried nothing, I think there's arbitrary number I'm picking out of hat, but at least 60 to 70% chance that at least buys you some time, which is important.
Excellent. I would agree with you. I think a lot of patients, I share the same concepts. I think patients that haven't tried, and sometimes you talk to them and you see that the conservative treatment was not really well done or managed properly. And then if they follow instructions, if they are compliant, a lot of them just give up on the initial thought about having surgery. So I agree with you as usual. So does Coughlin-Shurnas staging influence your treatment algorithm? Alexandre, tell me about that. How does that influence your let's say, like, we're not talking about conservative anymore. We're talking about surgical now. How do you use this into your decision making? Does that influence you? I mean, if the X-rays or the clinical aspects are different, how just give me, I know it's tough to give like the whole algorithm to decide it, but how does that influence your thoughts?
Great question, Cesar. Thank you. I think that it's a useful system for decision making. For me, grade 0 is non-surgical treatment. Grade 1 and 2, I prefer chelectomy. Grade 4, arthrodesis, and grade 3, it's a green area that you can decide about what procedure you will done based on other questions related to the patient. The only important factor that I miss in this classification system is the grade of alignment of the hallux in the axial plane, especially.
Well, so you definitely go by the books. I mean, 1 and 2, chelectomy. 3, you have options, and 4, you go for fusion. Well, thanks for the. I would disagree, but I mean, I don't use the classification a lot to decide. I go more with the profile. But yes, I consider some of the physical and the radiographic findings. We're gonna talk about my treatment algorithm soon, but there's nothing wrong. I mean, I think it's an interesting classification system. I think it doesn't cover everything, but you definitely can use some of the points in the classification system to decide your treatment. So let's go to some controversial stuff. So metatarsus primus elevatus or first ray instability, fact or fiction? Dr. Drakos.
Thanks, Cesar, for having me. I think it's a fact. I think that you can have several different causes for Hallux Rigidus. A long first ray may be one of them, an alignment issue may be another one. With regards to metatarsus primus elevatus, a lot of times that'll present as a dorsal bunion, and the dorsal bunion and that instability will cause pain, and there may not even be a lot of arthritis in that type of scenario. But I don't think that's obviously the only reason you can have Hallux Rigidus. I think there's lots of different reasons. And just to touch on what you guys were saying before about classifications, I think the classification would be great if there was an absolute correlation between clinical symptoms and pain and how bad it was. But unfortunately, there's really not, or it's very, I would say, loosely classified. So when I'm evaluating these types of patients who have an elevated first ray, I will also kind of go with the conservative management first. But if that is the case, then that's someone who you'd think about stabilizing the first ray and bringing it down in addition to potentially doing a distal procedure as well. So I think if you have, an obvious cause, then certainly you should address that at the same time. But certainly it's not the only cause.
Excellent answer. I do have a question for you guys, but let's Lauren. Lauren, anything to add about that? What are your thoughts
Sure.
about the metatarsoperimus elevatus?
Sure. I mean, I think it's, there's evidence suggests, and I've seen it as well, that patients with hallux rigidus do have an elevated first ray, more so than individuals with other problems like hallux valgus and what have you. I think it's a bit of a chicken or egg question in my mind of, is it the cause really, or is it just, correlated that yes, people who have hallux rigidus, we're going to see this more commonly. So I think it's something that if someone's presenting, as Mark said, with more of a dorsal bunion, then I think that becomes more clinically obvious. But more commonly, I find when I see patients where I wonder if they're a bit elevated on their preoperative imaging, I wonder how much of that is postural. And that's something that really is forefront of my mind, making me probably lean a bit more to the fiction side than maybe Mark was saying. Because a lot of patients I have very classically say, I know I have big toe arthritis, but then why do I have all this pain on my dorsolateral midfoot? They don't say that, but they point exactly there classically every time, suggesting that they're overloading while they're walking, while they're standing, which you see clinically. And that supports that perhaps they're posturing that way in their x-rays as well. So.
Yeah, I mean, that's the controversial part. I mean, some people would say, well, they walk on the outside of the foot to avoid putting pressure on the first ray or putting the load through it, and that's the reason for the metatarsoperimus elevatus. And I mean, I don't have the answer, of course, for that. I do believe in it. I think it's part of some, if not most, of the hallux rigidus instability of the first ray. So my question to you guys before we move to the next one is: so is there any room for cotton osteotomy? I know the cotton is going to make the first ray even longer, so we know there's some pressure on the first MTP joint, but is there a room for a plantar flexion osteotomy of the first ray? Who would do that? Dr. Drakos, Lauren, are you guys doing that?
I've never done that. I mean, I've done a lapidus to address instability and bring it down and keep it down. But I think doing a cotton, you elongate the first ray and you increase pressure at the joint, which is probably counterproductive. But again, kind of going back to what we were saying before, I don't think you can lump all these into the same etiology. I mean, some of these patients will have like an acute OCL from an injury that becomes arthritic, and then some will have some sort of alignment issue. You can get, hallux rigidus with hallux valgus as well. So, I think you have to be careful about painting with too wide a brush when evaluating.
I agree. Lauren, anything to add?
No, I certainly agree. And I think there's just so many other factors. And, hallux rigidus is one more than others in terms of an entity where we don't know exactly the underlying, equation that causes this every time. So I know I haven't done a cotton. I don't think that's, right at the surface of my toolbox for this type of case. I think if I was planning to do a joint salvage procedure and it was quite an obvious dorsal bunion, I think I would consider realigning the first ray, but I would worry about, too much increased plantar pressure versus the elongation of the first ray, as Mark said. But I have, interestingly, just in the last week, had a Cartiva implant or interpositional arthroplasty that had come back and had very significant postoperative elevatus, far more than his preoperative imaging suggested. But I wonder if that's something that's slightly missed that should have been addressed differently, or did he develop that because he was stiff after his implant? So I think it's something real to consider.
Great discussion. Let's go for one more. So functional hallux rigidus or gastrocnemius contracture. So do you guys believe in a patient that if you plantar flex the ankle joint, then the hallux rigidus is gone and you gain the dorsiflexion that you're missing? Alexandre.
Very nice question, Cesar. I believe that Achilles calcaneus plantar system can represent one factor for functional hallux rigidus. However, I do not identify in my clinical practice many cases with the exclusive etiology. I agree with Monteagudo and Mancieira that many symptomatic patients with this diagnosis go well with non-operative treatment. And if you indicate a treatment, a surgery for this kind of patient, never do only the procedure, gastric release. You need to add some osseous procedure for treated.
Good. Let's see, Dr. Johnson, you're a strong supporter of gastrocnemius recession, gastrocnemius contracture. What are your thoughts about this?
Yeah, so I think there we go. I'm sorry about that. Yeah, I'm a believer in the causation of gastroc. I think our understanding of the implications of a gastric contracture on pathology in the foot and ankle is still evolving. And we know that it has effects both in the hindfoot, the midfoot, as well as the forefoot. And just as we talked about in the previous slides, that elevatus is a real factor in evaluating these patients. And that elevatus has to come from somewhere. And so I do think that extra pressure that's passed on to the forefoot in some of these patients is a contributor. Now, I do think that, as Alexandre said, how to go about best treating that equinus along with the bony deformity. I think our understanding is still evolving, but I do think that if you examine these patients and you plantar flex that first ray and it's offloaded, essentially, that dorsiflexion is very good. If you load it up in that dorsiflex position, that motion goes in several of these Hallux Rigidus patients. So definitely that gastric equinus and maybe that secondary mobility of the medial column are both factors that go into this functional Hallux Rigidus.
Yeah, I agree. I totally agree with that. What would you say, Dr. Johnson? What is the percentage of your Hallux Rigidus? Doesn't matter what you're doing. Let's say you're not doing a fusion, of course. In a joint salvage procedures for Hallux Rigidus, what would you say is the percentage you would do a gastric recession as well?
So I think somebody that comes in and has, pretty marked equinus has a little bit of that elevatus already, and I feel that equinus is contributing to that. And so if I'm going to do a joint sparing procedure, I want to help address some of those mechanics coming from the gastroc to give them the best opportunity for that joint sparing procedure to last them many, many years going forward.
So just give me a number. I've been doing more and more. So would you say 20-30% of your cases of joint sparing, would you say you're doing gastric recessions with it? Coughlin-Shurnas is gastric recession or something like that?
I'd say about a third, and it tends to be kind of the younger patient with a little bit more instability and hypermobility of that medial column as well. But I'm shying away from a lapidus just at that point because I feel that doing the gastroc will help give me the release of pressure that I need.
Good, excellent. Well, I've been doing more and more as well. I don't think I'm 30% yet, but maybe 15, 20. Easy. Just let's skip you, Dr. Johnson. Describe for us just briefly your ideal colectomy patient? What would be it?
All right, so it's going to be a younger person that has really just pain at the extremes of motion, and really is the one that comes in complaining of pain when they really dorsiflex their toe. They're going to have a stable medial column for the most part, and on X-ray they're going to have a sizable exostosis. And so that's the patient that's going to do really well with a colectomy, just with that clinical presentation.
Excellent. I have questions for you about this, but we're gonna talk about it because we're gonna come back to some factors that would influence that. So that's why I'm not gonna ask you now. Dr. Drakos, describe how do you decide when you do a Moberg or no Moberg?
So pretty much all of them. And I based that on a study Marty O'Malley did in JBJS a few years ago, where he added the Moberg to all of them. And basically the patients did a bit better. I think, we actually did a biomechanical study looking at this at our institution. And, the Moberg does two things. It decompresses the joint a little bit, and it also shifts the pressures plantarly. So most of these, the wear is usually dorsal. Sometimes, obviously, it can be pervasive and plantar and involve the sesamoids, but most common is dorsal kind of wear and plantar sparing. And so by adding the Moberg and shifting the pressures plantarly where you have better cartilage makes sense to me. And then, when you take out the wedge, you take out some of the stress from the soft tissues as well, from the EHL and FHL. So, kind of what we were saying before, if you added the cotton, to this to increase the length of the first ray, you may be increasing the stress on the joint. Similarly, by taking a wedge out of the system, you probably are decompressing a bit. So for me, it's pretty much every time. The only time maybe I wouldn't do it is if I had an acute kind of osteochondral lesion on the metatarsal head from a trauma, where I was just going to do a cartilage procedure in like a young person. But I don't feel that you lose a lot by taking a wedge out. Most of the patients clinically don't notice it. They do lose a little bit of plantar flexion, but the increase in dorsiflexion, which is the more functional range of motion that they need, I think is worth this every time.
Very good. That's it. So in other words, if you're sparing the joint, the Moberg is going to be there. It doesn't matter what you're doing. Chelectomy, interposition.
Yep, doesn't matter.
Good. Very interesting. So that's a tough one, Alexander. So the polyvinyl alcohol hydrogel, for me, it's also an interposition arthroplasty. So I just put the three most commonly used interposition arthroplasty techniques here: the acellular dermal matrix, the EHB, and the polyvinyl alcohol hydrogel. Describe the ideal interposition arthroplasty for you, Alexander.
Great point, Cesar. You know that we have a recent systematic review published in Journal of Foot and Ankle Surgery in 2018 with 12 case series studies and 3 case control studies. And also the group of Cartiva motion study group, both showing the interposition arthroplasty is an effective treatment option for grade 2, 3, and 4. But my ideal interposition arthroplasty patient is the Hallux rigidus without deformity in the axial plane that need osteotomy for correction. Hallux rigidus grade 2 or 3. First metatarsal sesamoid joint free for osteoarthritis, and patients who clearly prefer to maintain the range of the motion and accept the risk of revision in the near future.
That's a good one. I would agree. I mean, as you're going to see, I always push to no fusion. I'm probably wrong, but I try at all costs not fusing the joint. But I like your justification. I'll buy that. So, Lauren, chelectomy, failed chelectomy. What do you do now? Do you try something else, or you just say, well, let's go for fusion?
Sure. So I think the first question is, why did it fail? If I've done it, then I know, that I feel like I've done the best version I can do. If it's coming from elsewhere, which I know we all do have, then it's a question of, was there unrecognized sesamoid arthritis? Was there an indication, as Mark had said, for a Moberg that wasn't completed? Was there some reason why we think that we can make it better and still salvage the joint? And then next steps for that, if we're going to continue to try to maintain motion for them and considering a polyvinyl alcohol composite implant, do we have the bone stock for that? So further imaging, like a CT scan, to determine, what the bone stock is like, how much of a dorsiflectomy did they perform, to see, is there an option in my hands to maintain motion? And I think at the end of the day, it really is going to depend on the patient's willingness to undergo another operation. So if they are already right at the get-go saying, I want one and done, that's it. I want one and done to get on with my life. This has already been a bit of a, not ideal course so far, then we stop there. We do a fusion, and that's a fantastic operation. A lot of my happiest patients are MTP fusion patients. So we'll go back and forth on that a bunch, I'm sure. But if there's someone who said, oh gosh, that sounds horrible, I don't want that. Then we go down that path with the CT and just make sure that they are, appropriate candidate to consider it.
So let's say it was your patient, you did it well, perfectly technique, and you saw the cartilage, and we're going to talk. I mean, the clinical radiographic dissociation when you look intraoperative is usually important, in my opinion. Like you look into the X-ray, you think it's not that bad, and you open, there's no cartilage, and you're still, I mean, depending on what you talk to your patient, you still have to go with the chelectomy. But let's say you did your chelectomy, the cartilage was not super good. I mean, let's say 45-50% of the cartilage was gone, but most of the pain was dorsal. And patient with the fail was, I'm still having pain, Dr. Roberts. It hurts me, and when I move, it hurts me, and when I walk, it still hurts when I try my dorsiflexion of the first MTP. Yeah. So does that make your life easier? What would be your answer to, I'm your patient?
Yeah, sure. So I think number one, something I hadn't mentioned before too, is the timing of this, because we know polyvinyl alcohol and interpositional arthroplasty, they are going to take longer to get better, and it may, there is a chance of failure. Does the patient, or do you want to undergo that possibility of now having a third operation? Because anyone that I sign up for a salvage type procedure, you're signing up kind of assuming we're going to have to do a second operation in your life. And that's the way I sell it. And if they say, that's the worst thing I've heard, you lost me, then that's the end of the conversation. Yeah. But it comes down to a personality thing. In your life experience, what sounds worse, a second operation or not being able to move your toe? So I think if you were my patient and we had done a fantastic chelectomy and the joint looked not so great, but we had planned just for, a chelectomy, and you didn't develop sesamoid arthritis in the interim, if you really wanted it and you had the bone stopped, then we could, keep the joint and do an interposition. But that's going to be your decision. I kind of lay it out and let you choose.
No, I agree with you. I think at the end of the day, you sell all the possible, and you share the data. And then the fusion, as we're going to talk here, is for sure the gold standard for failed and more advanced Hallux Rigidus. But at the end of the day, you provide pros and cons, and at the end of the day, the patient decides what they want. My experience, even with the Iowans, I feel that as you explain more, most of my patients, at least, they prefer not go with the fusion. But there are some of them that agree with you. They just say, "Oh my gosh, no, I'm a farmer. I want to keep doing my crop and just get one and done." And then that would be the fusion. So it's going to go in the same lines here, but let's move a little bit quicker so we can get to the cases. But failed interposition. So you tried. There's some reports now with failed polyvinyl alcohol hydrogels. It's just one of the papers, but so you have a patient that you did that, Dr. Johnson, and they come back, they're still in pain. You have some imaging that shows some osteolysis around the implant, radiolucencies. So what do you do now?
For me, this is a fusion every time. The key is to assess the amount of bone loss that you do have and have a plan to address that bone loss. So that's a fusion augmented with some sort of bone graft to make up that deficit that they do have from that previous implant.
Yeah, I think that's an easy. I mean, you could still try something else here, but I agree with you that the fusion would probably be my solution here as well. We would have. I mean, maybe we're not going to have time to get there, but if you have a short, let's say you lost bone here, what is your cut for considering distraction arthrodesis, Dr. Johnson? I mean, of course, a short first ray or short first metatarsal, but do you have a threshold? I mean, how do you decide that? How would you say we need to put some bone here? We need to put an like a distraction piece of bone here.
Right. Yeah. So I use kind of the lesser rays as kind of my benchmark or my barometer to kind of tell how short that first ray is. I'd say if it's greater than probably about 5 millimeters or so, specifically compared to the contralateral side. And I feel that if I don't address it, that I'm going to get some transfer metatarsalgia. That's when I'm going to that distraction arthrodesis.
You mean 5 millimeters in comparison to the second metatarsal, or in comparison to the other first metatarsal?
comparison to the first of the
To the other
contralateral
foot.
side. Yeah, the contralateral
Got it.
side.
Any role for first metatarsal decompression osteotomies, Alexander?
Well,
Can you
Cesar,
do that?
it's a very difficult question. We know that exists many types of osteotomy for this decompression in Hallux Rigidus. The literature is not so strong in terms of evidence, and I've never performed this kind of osteotomy. I don't know the rest of the panel, but I never use it in to treat Hallux Rigidus.
Yeah, same here. I've seen some cases with failures. Any of you guys, Dr. Drakos, Lauren, and Dr. Jones, any of you would do? We talked a little bit about this before, but any of you doing or at least considering this kind of osteotomies?
That's not part of my practice currently, Cesar.
Yeah, same here. It hasn't had a role in my practice as of yet.
Me neither.
Dr. Drakos, what patient
Yes.
would you definitely not fuse? I mean, we talked about this a little bit, but I'm trying to get the patient that would say, well, that it's definitely not a fusion. You cannot say the patient that asked for not having a fusion, okay? It has to be something else.
Yeah, I mean, I think it goes back to, what Lauren was saying about the patient's kind of personality. If this is someone that needs to be in high-heeled shoes, they're clearly not going to be happy with the fusion. In terms of sports, we did another paper looking at return to sports with the fusion, and some of those patients actually did pretty well. There's about like a 70 to 80% return to sport, which is not great, but not horrible either. There's at least one professional tennis player I know of that has an MTP fusion. But as a general rule, I'm not going to fuse someone who's younger, athletic, who has good motion to start with. I definitely am kind of a joint preserver. I don't even do ankle replacements. I try to save joints, not get rid of them. But certainly someone who really needs the motion, someone who's into yoga, certain sports that they're very into, I would definitely not fuse. I tell them fusion is kind of the last stop on the train. So if you're younger with any sort of motion, you're probably not going to get a fusion in my practice.
I agree, 100%. Let's do the opposite, Lauren. What is the patient you would definitely fuse it? So.
Yeah, I think it's kind of extension of the same things Mark was just going through. At the end of the day, I have a conversation where I talk about, the gold standard is fusion. A lot of my happiest patients, as I mentioned, are first MPP fusion patients, but where you end up has a lot to do with where you start, obviously. And so if they're coming in with a lot of motion, grade 1, grade 2, and motion seems like it'll be really important to them, then certainly they wouldn't be in this category. And I kind of gauge when I'm explaining the options to them, do they react, with a big reaction when I say the possibility of a second surgery, or do they react when I say they won't be able to move their big toe? And that's, kind of what it comes down to. There's certainly patients with, advanced age, low functional demand kind of at the onset, where, fusion's favorable. That said, I have done, more joint salvage operations in older patients than I thought, because the rehab can be slightly quicker. So there is actually a role, and age is just a number, and it doesn't dictate things fully. But patients with any significant deformity, significant bone loss, patients who may only be a grade 3, but they've got significant osteophytes and erosion through the base of the proximal phalanx, not just metatarsal head side, I would favor probably just fusing.
Age is just a name, it's just a number, isn't it? That we discussed. So we're going to go through quickly here just because of the sake of time. So symptomatic sesamoid arthritis equals fusion for you guys. Let's do some yes or no here so we can move forward. Dr. Johnson.
I'll give you just a quick yes, because I think that arthritis is a little bit more global than just the sesamoids a lot of times. And so usually, to me, that's a little bit more advanced of an arthritis. And so, again, they're either looking at a fusion or potentially a joint salvage plus a separate procedure to address the sesamoid arthritis.
For example?
Potentially
Sesamoidectomy?
sesamoidectomy. Yeah.
Got it. Lauren?
Yeah, I think this I hadn't included in what I was saying before, but I mean, any MTP joint arthritis with sesamoid arthritis is a full stop. That's a fusion for me. If someone were to come in with isolated sesamoid involvement of one sesamoid and they're young and active, you could consider, the other procedures, as Michael was saying. But for the most part, this would typically go to a fusion in my hands.
We talked about this, but any additional comments? Grade 3, fuse now and get it done. Depends on the patient, is what I understood from your conversation. Dr. Johnson, you want to add something about it?
I would echo kind of what everybody else had said previously. It's a conversation with the patient. What do they value? Do they value a one and done? Or is that motion, the little bit that they do have, important to them?
Dr. Drakos, anything to add?
Yeah, I would add, like, for the grade 4s, what I tell patients is that, you don't have any motion now, you do a fusion, now you have the same motion without pain. So it's a pain relieving operation. And those patients actually, I think, do very, very well. Because they've been kind of dealing with no motion for a long period of time, almost forget what it was like. So I think those are very reasonable people to fuse.
Hey guys, Cesar, we have a question here. What do you guys think in the setting of a hallux valgus with a hallux rigidus? What do you do?
Great question. I would say it depends on how bad the valgus is. And I mean, I usually try to, is this an hallux valgus that became arthritic, or is this an hallux rigidus with a minor deviation in the axial plane, if that even exists? And I would focus my treatment. If I think it's more an hallux valgus that's not arthritic, I would think about my hallux valgus algorithm. If I think it's an hallux rigidus with some axial plane displacement, then I would use my hallux rigidus and consider, for example, like the aching Moberg osteotomy if it's small axial plane deformity. But who wants to jump into that? Anything to add, guys?
Sure. I would say for a lot of our bunion patients, you'll see defects on the metatarsal head. And to be honest with you, for the most part, for the small ones, I've kind of ignored those and just tried to address the deformity. Over time, that you would think that by alleviating the pressures on particularly the lateral side of the head, you would think that that would improve symptoms as well. But I haven't necessarily gone after the cartilage defects on the head in a bad hallux valgus unless it was severely arthritic where the whole joint space was narrowed after you had a correction.
All right, I got one other question from the crowd, if you're up for it. How do you guys justify your belief in metatarsus elevatus, yet not offer plantaricizing the distal metatarsal osteotomy?
Well, from my standpoint, I think it's like Dr. Johnson mentioned. I think it's a combination of things. I think it's a mix of gastrocnemius or gastrocnemius contracture and the pressure of the phalanx coming down and pushing the head up. I think it's also a combination of the instability of the first ray or the medial column. I usually, when I think the metatarsal elevatus is something really important, I haven't done cottons, I haven't done first ray osteotomies, but I've seen people doing. But I usually add a gastrocnemius recession with my hallux rigidus case. That's the way I address metatarsus primus elevatus when I think it's an important component of it. Anyone want to add?
I would just agree with you. Yeah, I would agree with you, Cesar. I think if you're going to address the elevatus with whatever you want to do, whether it be a lapidus or an osteotomy, and not address the equinus, I wonder if that just doesn't set you up for a little bit more rapid progression of arthritis that they already have at the first MTP joint. So I agree with you. I think the equinus and the stability of the first ray go hand in hand, and I feel that you need to address both of those things.
Anyone else want to add something? I think we have a quiet crowd. So total or Hemi arthroplasty of the first MTP does not work. Factor fiction, quick, so we have to get to cases. Alexandre, does it work or not work?
I have a small experience with Hemi arthroplasty. We published a case series, 20 patients in 2011. I think that it's not a good option because in the midterm follow-up, the outcome is not good, and the revision in this situation is very, very difficult to them.
Dr. Drakos, anything to add?
Yeah, there have been a number of studies kind of looking at longer term outcomes with this. There's one FAI, I believe, 2017 or so, and the failure rate was about 50% in terms of implants getting loose. So I have not been a fan or had a great experience with the arthroplasty. I've taken a bunch of them out, but I haven't put many in. I think it's a hard joint to get, stable integration of these implants because the pressures are so high and the joint is so small and the relative surface area is so small for bony ingrowth.
I agree 100%. And for me, it's a fact. I also don't do it, and I think it's not a good option. So I just want to quickly run through. I mean, that's the way I think. I usually explain the concept to the patients of the arthritis, make sure that they understand what is going on. That is an ongoing process, like Lauren mentioned here. They have to understand that if they want to do a range of motion preserving procedure, and I usually say range of motion preserving procedure because some of them are very aggressive, so they're not joint preserving, in my opinion, versus a fusion. If they're willing to do it, then I kind of divide the joint. I call them joint destructive because they do cause some destruction of the joint. Interposition arthroplasty is the polyvinyl alcohol hydrogel, and I don't do the joint replacements. If they want some joint sparing, then for me that is scalectomy. I don't do the osteotomies. If they want to stop the process forever, then it's a fusion. And then for me, it's literally an intraoperative decision if we're going into the range of motion preserving procedures. From the clinical radiographic dissociation, I mean, you open it, it's much worse than it looks like. Sometimes I feel bad to just do a chelectomy in a case like this. So the way I decide between chelectomy, polyvinyl alcohol hydrogel, or interposition arthroplasty, the way I use a acellular demo matrix is number one, I tell them, I always consent them for chelectomy versus interposition arthroplasty, and then I decide preoperatively if I'm going to do a polyvinyl alcohol hydrogel or the acellular demo matrix. And the way I decide that is if there's plantar pain or sesamoid pain, I usually go with the interposition with the acellular dermal matrix because that covers the sesamoid metatarsal articulation, and the polyvinyl alcohol hydrogel does not do that. I'm not a fuser. In my mind, biomechanically, some motion is better than no motion. I go the same line with Dr. Drakos on that. I try to push the limits. I almost always offer range of motion sparing procedures. Contraindications, the only one that would be for sure probably infection. Relative contraindications, failed prior attempts, very short first rate, very, 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 very limited range of motion. One and done type of patient like we discussed here. But I tell the patient, look, if you want the gold standard, the Pelé, the best one, the best soccer player ever, that's the fusion. And like Dr. Drakos mentioned, they have a paper showing that you can go back to physical activities. But I think the results with joint preserving procedures is really good if you know how to do it. So let's run through cases here. We have 15 minutes. This was a 54-year-old female patient with a prior chelectomy in 2013, then revision chelectomy with Moberg 2015, came to see me with still having pain, pain with range of motion, 25 degrees dorsiflexion, no plantar flexion, and she had an EHL contracture with hyperextension of the IP joint. You can see here in the x-ray. Lauren Roberts, what to do?
I would probably offer this patient a fusion. Other options I worry about, if you have to lengthen the EHL and then you've got this joint you're wanting to move, but your EHL is then weak, I don't feel I've done them any favors. So I would offer that patient a fusion.
Well, I talked about it. We talked about fusion for sure. But this patient, after explaining of course, I'm kind of probably biased and I push the patients out of the fusion a little bit. But we talked about it and we ended up going for interposition arthroplasty. I do with the acellular dermal matrix. I use the technique that I've learned with Dr. Miller. This is where I'm going to run through quickly here so we can get to other cases, but that's the way to prepare the acellular dermal matrix. You put a bunch of, I'm happy to share this later if anyone interested. You put some 2 holes through the neck of the metatarsal so you can harvest with suture passers. You bring your acellular dermal matrix into those 2 holes and you push it underneath the metatarsal in between after you release the whole capsule and the collateral ligaments there. I use bone marrow. That's why it looks red like that. That's the bone marrow with Dr. Sean. And you pull it inside the joint. You see that I was waiting for the proper screwdriver to remove that plate and screws there. So that's why I didn't remove it yet. But you pull through the 2 holes and then you pull your use a zero Vicro for that, and you pull it underneath this metatarsal head. I already prepared my metatarsal head here to stimulate some bleeding, and you kind of graft jack that underneath, as you can see here. Then you rotate that. That's the articulating surface of the acellular dermal matrix. You can see there, and you're going to use additional sutures to the 2 sutures that you put through the hole, and you pass through the matrix or the acellular graft. That's the way it looks. And then you put some sutures there, and then you trim the edges, and it becomes like a sandwich like that. And even though it looks not super beautiful, patients usually do super well. You see the contracture of EA gel there, and we did a EA gel lengthening at the end. You can see here, and suture is the position of the toe. This is the intraoperative fluoroscopy. This is the toe saying, thank you so much, not fusing me. I'm so happy. And there's the patient with 6 weeks. And of course, the postoperative was complicated by this EA gel healing. The tendon procedure makes it more difficult. Usually when I do just the interposition with no EA gel, I'm very aggressive in a postoperative. This is the patient with 3 months. Still having the difficulty is to find the proper positioning of the EA gel, how much you're going to lymph it. And now it's the problem. When you look, you have to be ready to look to the weight bearing CT scan because it's frightening. You remove some bone to do that, and it doesn't look like the best joint when you look into the CT scan. But I can guarantee that patients do super well. This patient super heavy. She didn't want a fusion, Lauren. She was against the concept of having the fusion. This is her with 6 months. And she is happy. She's happy she didn't have the fusion.
Cesar,
Comments? Yes.
Did you perform some shortening the first metatarsal?
Good question. So usually, I mean, when you prepare the joints, the way Dr. Miller taught me and published on it is you do have to remove some bone from the metatarsal head, but you also asymmetrically ream your proximal phalanx. So you ream more the dorsal part than the plantar part. So you keep the insertion of the plantar plate. And that way, the likelihood that you're going to have a floppy toe is not as high. So you end up, in the preparation, you end up shortening. You have to be careful. Sometimes the bone is bad, like the same way when you're doing a fusion. If you're with the reamer, you could go just through and then make it too short. But you have to think that the graft itself is thick. So you have to consider that there's going to be a soft tissue interposing there. So you have to make it shorter so you open space to put the graft. Otherwise, it's going to be more even tighter. And then we go in the same idea that Dr. Drakos mentioned before of increasing the pressure into the joint. But I agree. I mean, the book answer would be a fusion, Lauren. But let's see, like Dr. Drakos said, just follow-up can ruin good results. So I'll keep you posted.
I was going to ask Cesar if you'd had to revise one yet. You say it's scary to look at that CT scan and we're seeing all this erosion and changes. I can only imagine what that fusion's like. So I wonder, what do you tell patients the likelihood of going to fusions and when? And then how do you describe what that revision fusion is going to look like for their experience in their life? Because it's not going to be a standard fusion.
Great question. Well, I think I've been doing some being aggressive with use of wedges, and I mean there's some MTP discs now, and or you can use autograft from the iliac crest if you want to make it longer. So my success with distraction arthrodesis are being super high. I think we have bone marrow, we have great bone grafts. So I get it. It's not going to be as easy as an infusion it would be today, but if the patient agrees that no, I want to try it, I want to keep my motion for 20 more years, maybe 15, maybe 25, maybe forever. Yeah, and if we have to fight later for a more difficult fusion, we will fight. We will fight together. But if they say, you know what, I don't want to go into that risk, then we do the fusion. But I think we can do very good. Answering your question, I think we can do good fusions, distraction arthrodesis with high chances of healing in this setting of shortening. But I try to shorten as less as possible. So I've been more and more. I'm removing less bone, and I can tell you with I don't have it published. I hopefully will publish my series in the next 2 to 3 years. But they are the happiest patients in my office. Patients love this procedure, love it. That's right. We have time for one more. We have 5 minutes for one case. Unfortunately, we're not going to get to the fusions, guys. Sorry. So 57-year-old again, with this X-ray, not as bad as the other one. Tried conservative treatment, didn't get better. So 30 degrees dorsiflexion, 10 degrees plantar flexion, some pain with mid-range pain, but not crazy. Dr. Johnson, we don't have a lot of time for more information, but better X-ray, some mid-range pain, most of the pain with dorsiflexion. This is the X-ray. No apexity for this one. I don't know how that happened, but I don't have it.
Right. So this is one that I would use kind of that mid-range motion to see if they had pain there or not. If you had pain there, I'd probably lean a little bit more into a fusion. If there's more just the big streams of motion, I might offer him a colectomy with a Moberg. But I'll tell you that some of my, 50, 60-year-old men who come in just because their foot hurts, right, their toe hurts, they do really well with a fusion. And so that would be the conversation I would have with him if he did have that mid-range pain. Talk to him about a fusion.
Well, that's why I usually say it's an intraoperative discussion as well. I mean, look at this cartilage. If some people would think about chelectomy here as well. I would say the mid-range pain was not terrible, but it's tough. This mid-range pain is something that I find clinically tough to be 100% sure. It's very rare that just pain with forced dorsiflexion. But this was the intraoperative pictures of the cartilage. Would you, let's say, you were thinking about a chelectomy here, Dr. Jones, would you change your mind when you see that? In other words, does intraoperative assessment of the cartilage would change your decision making?
I think it does. I think a year or two ago, this would be one that I would have considered doing a interpositional arthroplasty on. Since then, I've kind of moved away from that a little bit. So this may be one where I do a chelectomy, do a little bit of a microfracture of that absent area of cartilage, that little bald area right there, and then see how he does. And then it may be something that if he comes back, then we know that a fusion would be a good operation for him.
Yeah, well, this patient didn't have sesamoid pain, so I already knew that if the cartilage was bad, I was going for polyvinyl alcohol hydrogel. I don't have to teach you how to do this. This is easy. I just have a question before we finish. So this is the polyvinyl alcohol hydrogel going in. This is the final appearance. So before we go, and I know we're almost done here and we have to finish in 4 minutes, but how prominent are you guys, if you're doing it, how prominent are you leaving your polyvinyl alcohol hydrogel? Dr. Drakos, you're the first.
So I'm not doing these anymore based on the last study that we had done showing that the colectomy and Moberg did a little bit better. I think in Thordarson's initial paper where you had the high complication rate, they probably were leaving it a bit proud, like 3 to 4 millimeters, and that probably overstuffed the joint. by and large, the ones that we did okay, but I did a Moberg on every single one, and that may have been what helped it. And I tried to make it maybe a millimeter or so proud, or even close to like the remainder of the articular surface. The problem that we had with the Cartivas was that there was a number of patients that would still have edema in the metatarsal head. And I don't know why that is, but you could make an argument that some of these patients were older, maybe had osteoporotic bone. But the Cartiva is based on a friction fit. So you can get a pistoning effect, right? There's no ingrowth here. And I think that probably alters the normal mechanics. And so there was a subset of patients that still had persistent pain. We maybe made them a little bit better, improved their motion a little bit, but when you got post-op MRIs of these people, the metatarsal head kind of lit up like a Christmas tree. So I actually don't do this procedure anymore. I think we have better options. And for this one, I would do a collective Moberg and add some sort of graft, like usually BMAC and some like acellular matrix to the head as opposed to just doing a microfracture. That's what I would do now.
Interesting. Are you still doing, Dr. Johnson? If you are, how proud do you leave it? I mean, the original technique was 1 to 1.5 millimeters. When I do it, I still do it. I usually leave 2 to 2.5. I leave it prouder. I think it bumps it more. Of course, you can't overdo it. But if you're doing, how prominent do you leave it?
Yeah, so when I was doing them, I was leaving them about 3 millimeters proud, because I do think it did show a little bit of subsidence in some of the studies out there. And then also, if I'm looking to kind of maximize that range of motion, I'm trying to actually shift that center of rotation out a little bit to help potentially maximize a little bit more motion. So 3 millimeters for me was what I was aiming for.
Lauren, anything to add? We have 2 minutes.
I am doing them less than I thought I would at the onset of my practice and less over time. I had started initially doing kind of a generous 2 millimeters, but then, seeing my x-rays come back following this, worrying about the joint closing down too much too prematurely. And so it's probably now 2.5, 3.
Same here. Alexander, we have 10 seconds. 2.5. Good. Well, unfortunately.
Hey, awesome. I'll leave you with this one thought before you guys round off. Subsidence obviously is a theoretical, it is a problem with Cartiva. So you can actually get these base plates made. The 3D printing companies can make them a base plate that sits on the back side of the Cartiva and it has ingrowth. Because the base plate gets ingrowth, you don't get the subsidence then. And so you can maintain the 2 millimeter proud or 3 millimeter, whatever you want it to do. So I've been doing that for about 4 years now and it seems to be working. Cool. Well, thank you guys for being on this. We really appreciate it. You are the second to last. We got one more left and the 24-hour marathon's over. So I appreciate your time, guys, and your expertise. And we'll be back in a few moments.
Excellent. Thank you so much.
Thanks. Great job, Selene.
Thank you all very much.